Hello, my name is Dr. Rishi Manchanda. I am proud to be with you today. I am a primary care clinician, internist, and pediatrician. Have been with the National Health Service Corps now for the past 4 years, working in a community health center network in South Central Los Angeles. I'm also the founder of an organization called Health Begins, which helps clinicians by providing tools, trainings, and support they need to treat health where it begins, where we live, work, eat, and play. Today, it's my privilege to be working with the National Center for Primary Care, with PrimaryCareForAll.org, and with you to walk through what really excites me as a clinician, and I think will be relevant to many of your experiences, which is how to really provide a higher standard of care, and how we as individuals, as clinicians, and we in our clinic systems can excel in providing the best quality of care by specifically improving health where it begins. So I'm going to start today by leading us through some basic questions to understand really why I'm here involved in this webinar conversation with you, and hopefully engage each of you. As we go through this, what I'd like to do is to ask you at certain moments to pause during this presentation so that you can reflect on some of the activities that I'll help present to you, to try to both make a point about what our role is and could be as clinicians in addressing health where it begins, but importantly also to provide you with some time to reflect on these activities. So the first activity is really reflecting on why we're here today. As a clinician, I often think about when I'm in the daily practice of seeing patients coming in with acute care issues or chronic care management issues, I think about what bothers me the most about my job, almost as much as I think about what pleases me the most about my job. And I think for each of you, if we ask this question, what really bothers you most about your job? And conversely, what pleases you most about the job? What pleases me most about my job is the fact that I'm there in an environment with a patient, with an individual who, perhaps unlike any other environment, is able to quickly create a sense of trust, a connection, regarding the most fundamental of questions, which is how do I enjoy my life and thrive in my life, and how do I get past these problems that are surfacing, diabetes or headaches. It's an incredible opportunity to connect with somebody at an individual level. What bothers me about my job as a primary care clinician, and I think this is true for any setting that you're in, but particularly if you're in primary care, is the fact that many of the problems that walk in the door that these patients are carrying with them don't start in my exam room, certainly. And the tools that I have been equipped with through my years of training, in my case in internal medicine and pediatrics, through wonderful world-class institutions, many of the skills that I have received are great in treating the disease, but not wonderful in thinking of how to concretely help that person address the problems that brought them into my clinic in the first place. And I'll give you an example of what that means in a second. So I'd like to ask each of you to think about what pleases you most about your job, because really what we're talking about today is that. What's the fundamental reason that you're listening to this? What's the fundamental reason that you're working where you work? And conversely, what bothers you the most? Now, here's what I believe is the current standard of care, and this gets to a bit of both what pleases me about my job as well as what bothers me about my job. The current standard of care is best told through the story, for me at least, of Mrs. M, a woman who walked into my clinic not so many months ago. She's 33 years old, presented to our community clinic with a 4-week history of severe, throbbing frontal headaches. She was uninsured, and there were no other records available. This is not an uncommon story. In the prior 3 weeks before seeing us in our clinic, she had visited the emergency room at 2 different hospitals at least 3 different times. In that process, she received 2 CAT scans for her head, 1 spinal tap, and multiple blood tests, and each time she was told that her results were quote-unquote normal. Of course, this is her telling us this. She was given pain medications, and she was sent home with instructions to follow up with a primary care physician, whom she did not have at the time. So that's the current standard of care. What pleases me is that I have, as a clinician, I had the opportunity then to be there to help care for her. You know, clearly distraught woman with severe medical problems, losing time at work, losing the opportunity to really be productive and to thrive in her life, coming in and asking for help. And that's why I went into medicine. What frustrates me about my job is the story that I just provided you. No records that were available, and a system that seemed to provide multiple high-intensity testing, CAT scans, spinal taps, but with still no clue about what the diagnosis is, and certainly no sense of relief for Mrs. M, for this patient. And then, of course, me there on the front lines, receiving someone who's coming into medical care for the first time in many years, and trying to figure out how to deal with her issues and problems within 12 to 15 minutes. So this is her exam. She was anxious, had some mild maxillary sinus tenderness, and she had the classic allergic salute, which you might be able to see there across the bridge of her nose. She also had some mild cobblestoning on exam as well. And for many of you out there, I think for all of you out there, this probably raises a couple of key questions about both what this diagnosis is, to make sure that you're able to pick up using this history on the fact that she seems to have allergic rhinitis symptoms. She seems to have a bit of sinus tenderness and perhaps sinusitis, and that the headaches themselves may be related to the sinusitis, in other words, sinus headaches, or migraines, based on further questioning. So what other questions would you ask in this scenario? What I asked was, all right, more questions about her symptoms and the chronology of it, when they started, what makes them better, what makes them worse, all the things that we're trained to ask. And I also asked, as we're all trained to ask, about her environment. And I think that many of us would probably ask the same questions, and ask questions then that would lead us to making a better diagnosis, thinking about the adequate treatment, and if we're lucky and we have the capacity for this, thinking about how to prevent these symptoms in the future. Chances are, if you're a clinician like myself and the way we were trained, we would provide her with a treatment to take care of those allergy symptoms, ask a few questions about the environment, and try to help advise her to remove some of whatever environmental allergens we might identify in the 2 to 3 minutes that we're spending talking about that. Now, I'm going to give you a glimpse of a higher standard of care based on what we mean by going and treating health where it begins in a minute. But I want to just pause here and say that this scenario is a pretty familiar scenario, both for my colleagues in our community clinic where I have worked and in other settings around the country. It's probably best put by a wonderful hero out there named Dr. Pedro Joe Greer, who works in Florida and is a Presidential Medal of Freedom recipient. And he said it pretty succinctly: "What I do for a living is manage the consequences of bad policy." When you think about that, and you think about our training and the environmental questions that are raised in your mind as a clinician when you start seeing a person like Mrs. M, what we really do is end up taking care of those folks as they're coming into our clinics, not being cared for in their environment, or maybe suffering consequences of poor housing or outdoor air exposures that are unhealthy, to lack of insurance, etc. What we're doing for a living really is managing the consequences of bad policy, or perhaps, to better put that, the absence of good policy or better policy. So we're getting into a different area, but I want to bring this home and give you a glimpse of what a higher standard of care looks like for Mrs. M. So let's consider the story from the get-go again. She walks in, a 33-year-old African-American woman, and I knew something about her that her emergency room clinicians didn't know. In my clinic, in my health home, I knew something before I even walked in the door, which is that she had mold and water leaks in her home. And the reason I knew that as a clinician is because we asked that question based on the predominant determinant of health in the community where I worked, which is slum housing. So we incorporated those questions into our screening, and before I walked in the door, I already was primed as a diagnostician to understand the presence of mold and water leaks in her home. So we go on, and I did the exam just like we presented. She was anxious. It didn't change the exam necessarily, but it led me more quickly in the 12 to 13 minutes that I had with her to making an accurate diagnosis that she had migraines and allergic rhinitis. And what's interesting is that there's an association in the literature, as many of you may know, between migraines and allergic rhinitis. And we in the clinic started to classify allergic rhinitis, as well as other respiratory illnesses, based on the evidence in the medical literature as a housing-related illness. So we classify and categorize her symptoms, and that's what I did for her, which guided me to the treatment, which is not only to provide her a symptom relief. Here's the anti-allergy medications, here's the decongestants, here are the antibiotics for your sinus infections, and here are some medications for your headaches. We also provided her with the treatment that she needed to make sure that her symptoms do not recur, and that is a housing case management approach. Again, because that's the major determinant of health in the community, our clinic developed a case management program to go into the home and help her take care of the mold in her home, and when required, actually speak to the landlord and assist her with understanding her rights as a tenant. We also, of course, connected her, as many of your clinics have, to a benefits counselor and made sure that she was insured. We know that's a major determinant of health. And in general, this led to healthier outcomes. At the end of this presentation, I'll explain what happened with her. But clearly, an approach that allows us to treat both the symptoms, to manage the consequences of bad policies, but also to provide some interventions as clinicians and as members of teams that are both inside the exam room as well as outside the exam room, to treat those causes of health that are upstream, allows us, I think, to be better at achieving what the triple aim objectives are. And many of you are probably familiar with the triple aim objectives now, which are to lower costs, to enhance care, and to improve outcomes, particularly among vulnerable communities. So our goal today is quite simple in this webinar. We want to strengthen the ability of healthcare professionals like you and your organizations to improve health outcomes in your communities. And we want to do so really in the context of the triple aim that's been identified first by the Institute for Healthcare Improvement, and now that's been adopted through the Centers for Medicare and Medicaid Services and other leading health organizations around the country, and that is to enhance clinical care, to improve population health, and to reduce costs. So the learning objectives, just to go through them more precisely, we really want to make sure that at the end of the session you're able to describe and effectively communicate about the role of social determinants in shaping the health of your patients and your communities. We also want to allow you to be able to describe the potential benefits of a population health approach, an upstream approach, in advancing not only your clinic's strategic priorities, making sure the doors are kept open, making sure that you're meeting the bottom line of bringing enough revenue in so that you can provide services to a wide variety of underserved patients, but also that you're able to describe potential benefits of a population health approach to your own priorities as a clinician. Again, trying to improve the number of times you can quickly cite what pleases you about your job as opposed to what bothers you about your job. We also want to be able to ask you to describe components of an action plan to better integrate social determinants of health work into clinical practice. And as a clinician, I personally really am interested in getting concrete tools in my hands that I can use to improve patients' health, and that action plan is exactly that. We'll present that to you in a moment. We also hope that you'll be able to identify opportunities to leverage some of the innovations that are taking place under healthcare reform and some of the clinical tools that are now widely being discussed and available, such as the Patient-Centered Medical Home, electronic medical records, the enabling services you have in your clinic, and even new tools like Geomapping to improve determinants of health in your community and to really make sure that your model of care delivery is better. So this is all going to make more sense as we go along, but I want to walk you through the agenda for our webinar today. First, we'll describe social determinants of health, present the evidence for this, and then we'll move to the latter half of this presentation and talk through a really concrete action plan to move medicine upstream and to help you specifically to do that. So first, let's reflect, and this is one of those first activities where I'd like for you to, right now, write down the first word that comes to mind when I say health. Pause for a moment and write that one word down that came in your mind. And please make sure that it's only one word. As we, if you jotted that down, we'll move to the next activity, which is to consider, if you will, what are the one or two major social or environmental conditions that define the health of your patient population. Are you in a migrant labor community? Are you in a community that's in an inner city environment? that's plagued sometimes by substandard or slum housing? Are you in a community that is in a rural part of America where transportation access and barriers are major issues? Is unemployment particularly plaguing your patient population, etc.? Think about that or list one or two major conditions, and just jot that down, if you will, on a piece of paper while you're going through this. And when you've done that, you can pause if you'd like the presentation and replay. And if you've done that now, we're going to move to presenting the evidence of social determinants of health. And we'll come back to why those activities are so helpful in a minute. So the social determinants of health are the conditions in which people are born, grow, live, work, and age, and include the health system itself. The health system is seen in the framework of social determinants of health as a determinant in of itself of health outcomes. And this makes sense if you think about it based on your own experiences and based on what we know in healthcare in general. If you don't have access to a healthcare system because of lack of access to insurance or lack of coverage, that itself is going to lead to poor health outcomes. It's important to note that determinants that shape people's health are shaped themselves by the distribution of money, power, and resources at global, national, and certainly at local levels, and that is influenced by policy. This is political science 101. It's something that we aren't exposed to often in our clinical education, but I think we are uniquely positioned to bear witness to every day again in our exam rooms. It's clear that social determinants of health also contribute significantly to health inequities. Health inequities, for the purpose of providing a definition for our conversation today, are unfair and avoidable differences in health status seen both within and between countries and often over generations. If you think about that in terms of your own community, particularly if you're working with vulnerable or underserved communities, I think you understand how health inequities are not only pervasive, but can shape the life course of an individual as well as of a generation or more. We will describe briefly here some basic social determinants of health understandings, and this is just presenting some of the science that we know about social determinants of health. For instance, we know that social factors themselves are a leading contributor to mortality and morbidity. In this slide, which describes social factors and their contribution to premature mortality, it's clear that social circumstances, which are highlighted in that first bolded red section on the pie chart, contribute to at least 20% of premature death. And this is from an article in 2007 in the New England Journal. It's also worth considering that behaviors themselves are often dictated by social conditions and policies, right? The number of people who smoke is often related to our policies in terms of cigarette tax or other ways in which we incentivize or disincentivize that behavior. So if you add behavior patterns to the mix, it's clear that social circumstances and behavior, that social determinants of health in general, contribute to the vast majority of mortality outcomes in our country. And significantly, notice healthcare on the right part of that pie chart, and you'll see that healthcare, really based on all the evidence, and this goes back over the last 60 years and beyond in terms of our understanding in modern medicine, healthcare itself, our role as clinicians and healthcare professionals, really contributes to preventing 10% or more of premature death. So while we bear witness to and care for and apply our skills to improving people's health and preventing disease as clinicians, our proportional impact on people's lives, on the lives of entire populations, is not as significant as the social and environmental conditions that shape their lives in the first place. Let's consider education and health. Educational attainment clearly is linked to health outcomes. In this slide from the National Longitudinal Mortality Study run over a decade, it's clear that in the dark blue slides, which represent those who have less than a high school degree, and going to the lighter blue columns representing those with increasingly higher levels of educational attainment, life expectancy, which is on the y-axis here, improves. So the more educated you are, the healthier you are. That association is well documented in the literature, and I think each of you as clinicians can attest to this. Let's consider poverty itself and child health. Poverty by far is perhaps the most significant determinant of health. This is just one slide that looks at something that's compelling, in my eyes at least, which is poverty and child health specifically. And if you look at this graph, the dark green lines refer to those who, children who were born into families of high economic status, high socioeconomic status. The light green lines were those who were born into poorer families. And if you look at the Q score, which is their cognitive score, equivalent to their IQ, and look at their Q scores when they were just below 2 years of age at the beginning part of the graph, and track their IQ or their cognitive scores over time up until the age of 5 and beyond, you notice that those children who were born with high intelligence but were born into different socioeconomic backgrounds over time started to diverge in their cognitive ability. In other words, poverty itself led those who were born with the smarts, with incredible cognitive ability, to lose that cognitive ability and actually lose it, if you look at the right part of this graph, lose it to the degree in which their cognitive scores were lower than children who were born at lower cognitive scores but born into higher economic abilities, such that if you were born had a very high cognitive ability and born into a poor family, over time your ability to outpace somebody who is not as smart as you, not as cognitively proficient as you, but born into a higher economic family, you would be outstripped by that child who is born into a higher economic status. This is pretty significant, powerful research that we can certainly make accessible to those of you who are interested. It comes from a study that was done both in the UK. This graph is from the British cohort study specifically, but there are similar studies now underway in the US. Let's consider place and health. Now, the graph here is a little bit busy, but it's worth noting that the purple columns on this graph correspond to those who come from the most deprived income groups. So purple represents poverty. If you're in the gray columns, these gray columns correspond to individuals who come from higher economic groups. Now, if you look at each of the group 1, group 2, group 3, and up to group 5 on the x-axis, these correspond to the exposure to green space. So this is looking at different groups of individuals and how they're exposed to greenery in their environment, and then looking at that breakdown based on socioeconomic status. And what we see here is that the more exposed individuals were to green space, the lower the levels of inequity between the most economically deprived and the most economically affluent or advantaged in the community. So going from group 1, which had the least amount of exposure on the left-hand side of your graph, to group 5 at the end, you'll see the steady decline in the levels of inequity between those who are poor and those who are rich. And the variable here is its exposure to green space. So greener environments seem to be linked to lower health inequity in of itself. Place matters. There's also an interesting connection in terms of determinants of health between an individual sense of control and health outcomes. This study again comes from the UK, but it's also been replicated in studies in the US. This is a comparison of standardized mortality ratios for men ages 15 to 64 grouped by social class, and this is over a 50-year time period. These are specifically men in the British Civil Service, and what they found was that the mortality rates were highest for those who were unskilled compared to the lowest mortality being for those who were the most skilled. This was significant because these are individuals who are in the same cohort, the same type of environment, and differed primarily based on their own skill level. And what this study itself really represented was a breakthrough in an understanding of how social position, and particularly one's own sense of position in your society, can contribute to your health outcomes. What they found in this study and and what they found in other studies going forward is that your sense of control over your life, which is related to your sense of your position in society, has a direct impact on your health outcomes. So a sense of control, a sense of position in society certainly has an impact on health. These are just some of the determinants of health. Here's a story that brings us down home in ways that might be more accessible to each of us as clinicians, and certainly to our patient populations that we care for. There's a story of two women who come to the side of a stream, and they see a baby and a small child, and a mother and a father rushing downstream, clearly flailing about, but going down towards this waterfall. And they see another baby and another set of families experiencing the same problem, rushing downstream, clearly in distress. And the one woman jumps right in there in the bottom of the stream to do what I think many of us would do, which is to try to save those babies and save those families, bring them to the side of the river and rescue them. So she's there, this woman, valiantly saving people's lives there in the bottom of the stream, getting them to safety. And after a time, she looks up and she realizes that her friend is nowhere to be seen, the woman that came with her to the side of the river. And she looks up and she sees her friend running far away from her, all the way up towards the end of this forest, as you can see here, upstream. And she shouts to her friend, "Where are you going? You know, there's babies to save." And her friend shouts back, "I'm going to go find out who's throwing the babies in the water." When we consider our role in healthcare and determinants of health specifically, it's important to consider where we are in understanding our impact on social determinants of health. And I often think of myself as a clinician there at the bottom of the stream, really doing my best with my skill sets and with the teams that I work with side by side with the nurse practitioners, the physician assistants, the medical assistants, the case managers, everybody who's part of the clinical team that I work with, there to try to help people who are falling and rushing downstream. I think that's important and noble and incredibly rewarding work. I question if it's enough, and I question if it's possible for us to look up and consider who else is running upstream right now, and to think about what we can do to find out who's throwing babies in the water, and to figure out new concrete ways to prevent that from happening. This is a particular way of also describing to your colleagues, to families and friends, as well as to patients, what determinants of health are all about. If you move up from healthcare, clearly a determinant of health that's proximal to that is access to healthcare. Beyond that, people's behaviors. Beyond that, where they live and work, the physical and built environment. Beyond that, the social economic and environment that they're in, the policies that are set forth that provide them with social and economic opportunity, for instance. Above that, policies and political environment, which itself is shaped by the balance of power and people's own sense of control, again, in their lives. These are the social determinants of health. Now, and those impact clearly how people live, how they experience disease, if they experience disease at all. It's also linked to our ability as clinicians to work with others in increasing our efficacy and our capability to impact these determinants of health. This is not news to any of us. This may seem out there for some of you. This may seem entirely commonplace for others, because for many people who work in community clinics, this understanding of determinants of health is deeply ingrained in our roots. We started out with having a very significant biosocial history in the community clinic movement. Started out with a very strong emphasis on community-oriented primary care, which was inspired by a model of healthcare that some of the pioneers in the community health center movement, like Jack Geiger, came across when they were working in South Africa. It was mixed in with the incredible rise in awareness and commitment to civil and political rights that came out of the civil rights movement. It combined then with policy initiatives upstream, such as the war on poverty, and specifically with structural opportunities that were opened up subsequent, like the Office of Economic Opportunity. And those forces came together to create the community health center movement, at least as it was defined in the 1960s and for several years thereafter. So for many people, the community health center movement is a representation of this understanding of what's happening both inside the exam room and all those upstream determinants of health. So this may not be news to many of you. But what's happened over the years is that we've become professionalized, and rightly so. The original mission at the core of the health center movement changed really to keep health centers afloat, and we became more lean and mean, focused more on direct health services that to address the gaps that were existing, to really save those families that were falling downstream. In 2008, based on reports from the provided to the Bureau of Primary Health Care and HRSA, the vast majority of services and patient visit types, in the U.S. community clinic world were medical care services, followed by behavioral health and dental services, and about 7% of those services were enabling services. If you look at that light green wedge on your screen there, those enabling services really mean everything from case management to health education to transportation assistance to help with English proficiency or translation ability in general, and so on and so on. All of those enabling services really were at the core of the ability to bridge the biologic phenomenon in the exam room and the social phenomenon that were happening outside, and that formed the roots of the community health center movement. But over time now, in 2008, and I think it's still the case today in 2011, the vast majority of our emphasis really is spent talking about medical care, and perhaps less so on really developing our work around enabling services and those things that help us to bridge the divide in the community. And it raises this fundamental question, which is the current standard of care good enough? The current standard of care, as I described with Mrs. M, may not be satisfying to many of us, and perhaps shouldn't be. In the World Health Organization's reports over the years, one of them posed this question, which is, why treat people, then send them back to the conditions that made them sick? That really is what happens quite a bit in our current standard of care. We treat people and then we send them back to the conditions that make them sick. So we're in a situation where glimpses of the higher standard of care that allow us to prevent disease before it comes in the door, or to at least help take care of the social phenomenon that define people's health, our ability is obscured, and it's because there is a biomedical worldview. There are particular structural and policy incentives that have over years defined our current standard of care, and defined really what we do as clinicians every day. And it's not a leap to understand that this has had an impact on creating a vast amount of preventable illness, and has also perhaps contributed to health disparities. There's literature to support that. This has also exacted a huge economic toll on society. If we look just at the cost of health disparities themselves, based on a study provided by the Joint Center on Political and Economic Studies in Washington, D.C., health disparities themselves accounted for $1.24 trillion to our economy between the years of 2003 and 2006. This biomedical worldview that really treats people and then sends them back into the conditions that make them sick in the first place also means that we're providing less effective interventions. It's not effective to simply give someone an anti-allergy medication and send them back into an environment only to have them come back again. It's also not effective if we're not primed to think of social environmental conditions, because we might miss diagnoses, just like Mrs. M's diagnoses were missed in the emergency rooms that she had been seen in. This understandably leads to patient distrust, to a lack of opportunity for engagement, to what I call misengagement. And it also has implications for our ability to stay engaged as clinicians. It's not surprising that we have problems with workforce retention and recruitment issues, particularly in primary care settings across the country, in which many clinicians who bear witness to the biosocial phenomena that their patients experience often feel ill-equipped to treat those biosocial phenomena. In general, what's happening is that a biomedical worldview is obscuring our public health orientation and our ability to really improve the health populations. The WHO I referred to earlier, the World Health Organization, in 2008 was really called together to address this problem, and they created a commission on the social determinants of health. They wrote a seminal report called Closing the Gap. And according to the Director General, Dr. Margaret Chan of the WHO, who's pictured here alongside a pioneer in the social determinants of health world, Dr. Michael Marmot, according to Dr. Chan, the work of the World Health Organization really ended the debate decisively. Healthcare, she says, is an important determinant of health. Lifestyles are important determinants of health, but it is factors in the social environment that determine access to health services and influence lifestyle choices in the first place. They presented a conceptual framework to allow us to understand how health and well-being are impacted, and the framework is a pretty robust one. You have material circumstances and the healthcare system, connections to health and well-being, social position, and the interconnectedness there, the social political environment, and the interconnectedness there, and all of these as drivers for determinants of health and equity in both the U.S. and across the world. This framework is incredibly helpful, particularly for academics and researchers. It's not necessarily as helpful for clinicians who are looking to communicate these things directly to your patients, but we'll get to that in a moment. For our purposes today, I'm looking at and interested in working with you and thinking of ways in which we as healthcare professionals can engage in this. So our agenda really is to think about something concrete. There are a lot of different ways we can approach this, and for today's purposes, we're going to focus on one system innovation, which is the patient-centered medical home. Under healthcare, the healthcare law that was passed in 2009, called the Patient Protection and Affordable Care Act. It's called various different names depending on where you are in the country or the communities that you talk with. But the ACA, or the healthcare law, clearly has made an impact on people's lives and is perhaps going to do so for the foreseeable future by expanding coverage, by taking out cost sharing for preventive care. The creation of a prevention and public health fund is also something that's groundbreaking under this legislation, although it's questionable whether the funding for that public health fund will survive. It also infused billions of dollars into community health centers, virtually doubling the impact of community health centers within less than a decade based on the scope presented by this law. I think many of you, particularly if you work in community health centers, are probably bearing witness to the amount of energy and momentum that's been built up in your clinics, in your health centers, because of the ACA. It also expanded directly to the expansion of the National Health Service Corps, with a doubling there of the Corps and increasing the primary care workforce. It's led to the development of system innovations like accountable care organizations, and it certainly has spurred a national drive to bring our medical records into the 21st century through EMRs, electronic medical records. I think each of these is worthy of exploration in terms of how we can address determinants of health. For today, I'm going to focus on the patient-centered medical home, something that is probably new, not new to many of you. And this concept of the medical home dates back to the 1960s, first developed by the American Academy of Pediatrics. And what this medical home does is to structure a clinic to do everything it should do to provide the best care for patients over the long term. In 2007, the American Academy of Pediatrics, along with other medical specialty societies, set forth basic principles. These principles for a medical home meant that we should make sure that there is a trusting relationship with a primary care doctor, that there's a team-based approach to delivering care, that there's care coordination across all elements of the healthcare system, and that there's quality and safety to facilitate communication and to enhance access to care, and that the payment structures that really are the basis of how we structure our care in primary care settings, that those recognize the value of primary care again, and certainly should be in place to support the medical homes. So these guidelines were set forth and were integrated into the ACA. Community health centers, or CHCs, now have the opportunity through ACA and through other efforts right now at the national level and local levels to meet PCMH, or patient-centered medical home standards. And this is particularly exciting if you view this medical home as an innovation and a way to take a huge step forward to being more satisfied as a clinician in your ability to coordinate the care that our patients require. If you go through the elements of the standards that are presented on this slide, which was itself accredited to both the National Council on Quality Assurance, the NCQA, and the Primary Care Development Corporation based in New York. This slide presents really concrete ways, and if you look at community health centers and the work that we do, much of the work that we do and that we are poised to do is reflected in the medical home standards, which is why so many health centers are excited about their ability to become not only baseline or first level medical homes, but high tier and standout medical homes. So we can meet those standards in community clinics. If for many of you, I believe, work in community clinics, and this is a pretty exciting time to consider how the medical home can benefit us. Those benefits, based on the literature, can lead to reduced use of hospitalization and emergency room visits for our patients, has been demonstrated by a study there at the top of your slide. It also leads to could lead to a significant improvement in patient and provider experiences and the quality of clinical care. Again, what pleases you most about your job and what pleases your patient about their interaction in the care system. It's clear that the medical home, when done well, can improve people's experiences and perceptions about healthcare. It also improves the relationship between practices with the use of established systems and processes and the decreased use of emergency care. So there are multiple benefits, and this is why there's been so much energy and attention in incentivizing community clinics and other primary care settings to become medical homes. Here's the question that I want to present, which is, will the patient-centered medical home improve health where it begins? And while it's absolutely true that the patient-centered medical home movement is likely to improve biomedical care, it may not be enough to improve population health. And by that I mean this: where we're at right now, if you're a clinician who's involved in the medical home transformation in your clinic, or you're starting to learn about how to use electronic medical records, or part of any of the new system innovations that are coming into place in your environment, what's probably happening in your clinic as well is the fact that the enabling services that exist are still probably inadequately funded. They're probably not evaluated well enough, and that the costs of providing those enabling services are rising. And as importantly, very few of those enabling services or the other work that your clinic perhaps is doing or wants to do in treating health where it begins for your patients, little of that is well integrated into the medical homes. It's clear that across the country many clinicians are experiencing, and many clinics themselves are seeing, that they're not finding a way to connect the dots between the enabling services that they have been providing and the medical homes that are being incentivized now. There's very little data and funding to support public health interventions like the housing case management program that I described for Mrs. M, or for the numerous other public health interventions that are being pioneered in community clinic and primary care settings across the country. Very little data exists regarding these, and not surprisingly, there's not much funding to support this. And there are a few structural incentives to integrate and coordinate public health interventions in medical care. There's really not much happening at the structural policy level that we can see clearly in the clinical world that allow us to improve health where it begins. So the question is the medical home going to take us that one step forward in not only making sure that we provide better care for those who come to us, but in making sure that we send people back into conditions that are healthier. There are opportunities, though, and there's one specific opportunity today, which is to think about how to use the medical home reforms and other health system reforms under the healthcare law to expand and really leverage what we're doing in addressing social determinants of health in order to meet the triple aim. So if this is the mantra that I have been carrying with me with other clinics and among colleagues, and this is shared by, I think, a lot of folks, but if we do better by treating health where it begins, we actually, turns out, all do better, particularly if you think of the bottom line for the clinic. If we, for instance, use a new higher standard of care, which means a robust biomedical and biosocial approach, one that really doesn't allow medicine to obscure public health, but in fact puts medicine within the framework of public health interventions, there are many benefits that we can experience. Those benefits go beyond just improving the health of patients, which in and of itself should be reason enough. But those benefits can also mean professional satisfaction increases, that we have the ability to improve our recruitment and retention of the primary care workforce, and that we may be able to better achieve higher levels of the patient-centered medical home based on the current standards, and I'll show you how in a minute. We also might be able to experience cost savings so that we, especially if payment structures are changed, so that we're not doing fee-for-service as much as taking care of a capitated population of patients, we might be able to generate cost savings for our clinics as well. So the question is, how do we do this? Is it possible to do a little bit better? And the answer is that yes, we can seize opportunities provided by health reform, and we can use specific action plans to move medicine upstream to do so. So we're going to speak now about the action plan, and this is where it's all going to come into kind of specific focus for how to move forward. First, I want to present to you a model that is one among many models that are out there, but this one has been getting some traction of late, and I highly encourage you to review this using the link that's provided at the bottom of the slide. This model is called the Community-Centered Health Home, which is a spin from the Patient-Centered Medical Home, as you can see. It's developed by the Prevention Institute, and in full disclosure, I, along with some of my colleagues in Health Begins, have helped to inform this model through our own work. And this model, it really talks about basic elements in terms of inquiry and asking really where's the data on the community conditions that are driving people's health, and analysis, which means understanding these trends and identifying priorities with community partners. And it also means action. This model also includes action elements, ways to actually go ahead and engage in your clinic and in your community specifically. This is a wonderful model and a great resource, and again is getting a lot of traction that's out there, so I highly encourage that people review this, produced by the nonprofit Prevention Institute. What we want to do today is provide you with a concrete action plan to take that theoretical model and put it into action in your clinic. And the goal of the action plan is to improve your clinical care delivery model and improve population health by really understanding how to design, implement, and evaluate an intervention that impacts one or more social determinants of health. In short, what this action plan will allow you to do is to, today or tomorrow when you go back to your clinic, to think about ways to concretely move medicine upstream. This is entirely possible. This has been done by colleagues of yours across the country, and you yourself may be somebody who's already pioneered an approach along with members of your clinical team to address a determinant of health. And so we know that this is possible, and we know that there are probably no other people than clinicians on the front lines who are best positioned to move medicine upstream. So the action plan is a 3-step action plan with 3 components and a 6-step action plan with 3 major components. The 3 major components are design, implementation, and spread. And those are broken down into 6 different steps. For today's purposes, because of time and I think just to make sure that we're able to fully understand this, I'm going to emphasize the first 3 steps, particularly in the design component. Step 1, which is define the population. Step 2, which is to identify the intervention. And to step 3, which is designing an evaluation plan. Perhaps in later webinars or in other ways, we can share information about the implementation and spread part of the action plan, but you'll be able to follow along through this presentation today if you want to spend more time looking at this by simply just pausing the presentation and reviewing the content that's presented here. So step 1, in really mobilizing an action plan to address health where it begins. The first step is to identify your denominator population. What that means is the denominator meaning who is the target population that you want to help impact. There are generally 3 different ways of considering the denominator population. You can start with the patient population that has come into your office. For instance, the folks who have walked into your office in the past year. You can get more precise within that, thinking of adults or kids. You can also think about the next level beyond that, which is the practice community. In other words, not just your patients, but members of their households. That could be your denominator population. The step beyond that is the larger population. So those who may not necessarily come into your clinic or may not even be related to members of your patient population, but are there in your community. Those who are served by the schools or are members of a health plan in your community or part of the geographic community that you serve. These are clearly different levels, but it is important in the first step to really spend time in specifically defining your population as part of the action plan. Identify the denominator. The next step in defining the population is to assess community assets. And for each one of these, for those who are interested, we'll be working over the next several months and years to develop and refine these tools with your input. But here's the start. First, assess community assets. The second step, or sub-step under this, is to assess community needs. And that is specifically done through different mechanisms. And the simplest way is actually to use a quick survey or a quick phone call. Surveys through SurveyMonkey, for instance, or other sources can be wonderful resources to allow you to access and gather input from stakeholders in your community. Here's a short blurb or a script that you can use actually if you use the phone or send a survey out to assess the needs in your community among stakeholders, meaning the housing agency that works next door, the WIC or food stamp provider in your community, the folks who work on transportation issues or access to better food in your community. You probably are aware of these folks, and if you aren't, you can find out pretty quickly through, I'm sure, your network of colleagues in your primary care world. Once you identify them, you can survey them using a script, something as simple as this. At Clinic X, we want to work with you to improve our lives. We know that health begins where we live, work, eat, and play. And as our partner, as our neighbor, which conditions should our clinicians and staff be better equipped to address while working with you? I did this in my community clinic in South Central Los Angeles, and it was a wonderful exercise to both engage with collaborators in the community who are outside the exam room, and to start developing relationships that were really incredibly productive and constructive. Okay, great. I'll pick up again. So another step involves actually surveying your community stakeholders. You can use a script like the one that's presented there, or use any other simple script to contact stakeholders in the community. And this is a wonderful way to actually develop some really productive and working relationships with your colleagues. Many of you already may have working relationships with social service providers and agencies in your community. This is a way for you to ask them what services and conditions you should be better able to address in your clinic. This is a wonderful way to get started in defining the assets and the needs in your community. The other thing that you can do, this is the next step under defining your population, is to and in defining the major determinants of health in your community, is to use some and define some gold standard questions. How are the key determinants of health assessed in your community and others? I'll give you an example of what this means. I work in a community clinic setting which has come across a lot of problems related to housing. So what we did was to then find questions asked by the American Housing Survey across the country, and we looked for ways in which the American Housing Survey itself defines poor housing. We took those questions, which are validated and used across the country, and incorporated those into our clinical interface. So when I told the story of Mrs. M before and mentioned that in our clinic we started to ask questions about mold and water leaks, for instance, in our home, those questions were because we adapted them from the American Housing Survey. So find the gold standard of questions, and if you don't know, your community partners will likely know where the gold standard of understanding that determinant of health, whether it's housing or food or transportation, they'll know where to find that data or can point you in the right direction. There are wonderful tools that you can use to actually get a more contextual understanding of the needs and the assets in your community. One of them is geographic information systems, or geomapping. We mentioned before that place and health clearly matter, that place is an important determinant of health. And geomapping allows you to actually use a wonderful interface that the maps that can be provided through GIS software to provide a better contextual understanding of patients. And there's multiple benefits that are listed here on this slide. A wonderful resource for many of you, and feel free to jot this down and use it in your own work, is healthlandscape.org. You can use this as a community health center to map the needs in your community clinic environment. You can also get the Community Health View, which describes some major determinants of health that are specific to your community based on information collected through the U.S. Census and the American Community Survey. It's a wonderful mapping service provided by the Health Foundation of Greater Cincinnati and the American Academy of Family Physicians. I highly encourage you to use this. This is just this slide gives you a sample of what could be possible if you wanted to go beyond just getting a better contextual understanding for your clinic, but think about how to incorporate geomapping into your clinical work. This work is done at a clinic in East Los Angeles, and they decided to map their diabetic patients and sort them based on their A1C levels. So treatment responders, in other words, those with lower A1C levels, are there in the light green. Non-returnees or folks who had not responded to treatment, it turns out, were also folks with the higher levels of hemoglobin A1Cs, and they're represented there in purple. They realized after using this mapping tool that they were coming from different places, and they were able to target their health promotion activities accordingly. The next step is to define your population, and what that means is really to define the clinic priorities as part of this step and identify your internal stakeholders. And what that means is really thinking of what are the major pressing issues that occupy your senior management and your colleagues in the clinical world in your clinic right now. Is obtaining certification as a patient-centered medical home a major priority? Is selecting or implementing the EHR tool a priority? And so on. It's important for you to be able to describe the priorities that are occupying your clinic's time and resources right now, so that you can also take the next step in defining who are the internal stakeholders in your clinic. So if you're considering an intervention to move medicine upstream, you have to make sure that it's applicable to the working environment and the priorities of your organization and of other stakeholders in your organization. When you assess the internal stakeholders, it's important to understand what kind of impact your intervention, your proposed intervention, whether it's a housing intervention or a food security intervention, might have on their work. So do you believe that they themselves can cause low, medium, or high levels of disruption to your intervention? Do you think that this is going to require their scope of work to change in major ways? Will their view of the change be one which leads them to believe that this is a huge change, or that this is relatively minor and this is fine? It's important that you do this assessment before you go forward to avoid falling into predictable organizational traps and barriers. If you're able to map this out as you're defining the population and defining your intervention, you'll be leaps and bounds ahead in your ability to have an impactful intervention to address health where it begins. The step 1.5 here is to then go and define your patient groups. We talked before about defining the denominator, and now this is a way to drill this down even more. You can prioritize patients based on preventable diseases like diabetes, on complications of diseases, maybe it's the diabetics who have retinopathy, or modifiable risk factors like smoking, including determinants of health. And this is one we particularly want you to help think about. So, for example, diabetics who experience retinopathy, what is their modifiable risk factor in terms of determinants of health? Perhaps it's lack of access to transportation to see the ophthalmologist or to come to your clinic, or to come to the diabetic education classes or nutrition classes, or to your visit. Those are important ways to prioritize patient groups. So this is a way to get more precise. There are ways in which you can start to prioritize your patient groups if you use your EMR in ways that are interesting. So for instance, there are social environmental screening tools that myself and my colleagues have developed to integrate into your EMR. This is an example, for instance, of screening tools that we developed in a clinic in South Central called St. John's, which at the time was asking questions about WIC and food stamps and if they're having any problems with Medicaid. Those are ways for you to start to identify those patient populations in step 1. The second step then is to identify the intervention itself. And there are 3 different ways to identify the intervention, 3 different intervention tiers, if you will. The first level is thinking at the patient level. So let's say your clinic wants to do an intervention towards that particular patient population. You want to do home and health safety assessments, or you want to refer food insecure patients to food stamp programs, or you want to provide a partnership with legal partners to create a medical legal partnership, for instance. That's an example of a tier 1 social determinants of health intervention, what we call patient level. You're providing interventions that are geared towards individuals. The second level is tier 2, promotes interventions that are directed towards the patient population in a slightly larger way, at the population of the clinic or hospital that you're working in. An example of this is providing on-site farmers markets, which is what Kaiser and other clinics and hospitals around the country are starting to do. You can offer physical activity subsidies or programs for members in general. like providing on-site exercise facilities, which are accessible by all the patient population. So this is a way to think about your type of intervention. Are you tier 1, patient level? Are you tier 2, something that's accessible by all patients? Or are you tier 3, which is something that influences policy and programming interventions outside your clinic or your hospital? That means lobbying for increased cigarette taxes or promoting healthier benefits, healthier food packages in local restaurants, or advocating for street redesigns so that you have better access to parks. That's a third tier intervention. And some clinics out there, some of you as clinicians may be involved in these activities yourself, but this is a taxonomy to understand determinants of health interventions. And it's important in identifying your intervention that you are precise in thinking about what level, what tier of intervention you're going to be focusing on. Here are some more examples of intervention tiers. Food and nutrition, for instance, might be a determinant of health. And so if you wanted to do a patient level intervention around food and nutrition, that would be a food stamps program that you're going to better integrate with. A higher level, a higher tier intervention to address food and nutrition might be, again, providing farmers markets. An even higher level would be to be involved with your patients and your colleagues and stakeholders in your community to recommend improved food packages and healthier food packages in government programs, or in advocating for taxes on junk food. These are different types of interventions, and this slide presents ways to think about it based on the determinant of health that you're going to focus on. There are also considerations in terms of the cost and scale of these interventions. This triangular graphic here provides with understanding of the amount of work it takes to put together an intervention, and the trade-off in terms of number of people that you serve. As you get more intense with your intervention, such as represented by the top of the pyramid, the fewer patients you're going to impact. So it's important to consider what resources and capacity you and your staff have. More likely than not, you have very limited resources and very limited capacity, so you may be focusing specifically on devoting those resources to a small set of patients, but you could also consider using those limited resources to address as many patients as possible. But this is a way for you to start to, again, classify this and to articulate your intervention with colleagues. It's important to choose a good intervention, and that means making sure that staff are involved in that intervention choice, that you're considering whether this has been done already, and if it has been done, why it didn't work. Understand that this is going to conflict with priorities in your clinic, and to make sure that it's aligned with your clinic's strategic priorities. To understand if the scope is narrow enough. Is it a precise enough intervention, or is it too broad to demonstrate impact? Is it something that you have control over? If you're creating an intervention that you have no authority in executing, that itself can be a huge problem. And there are other considerations here as well. And again, through all these slides, feel free to pause and to jot notes down if you think that's helpful for you. So an activity to brainstorm on, this is one position to pause right now, is to consider what your major determinants of health are for your patients. You know, we, in the first activity in the presentation, actually asked you to identify 1 or 2 social conditions. Well, now what I'd like you to do is just brainstorm, take that same pad of paper that you were jotting down your notes on, and choose a sample intervention project that addresses that determinant of health in your clinic. This could be an intervention that's already underway that you want to help expand or refine, or it could be one that you want to start. But if you're a clinician who is interested in treating health where it begins and excelling as a clinician, then this is a way to start to move forward. So brainstorm about this. Brainstorm about whether you want to focus on a tier 1, tier 2, or tier 3 intervention, patient level, clinic population level, or general population level. And then, again, this is a good place to pause if you can. Describe it in 1 sentence. Use this construct here for that sentence. Pick a verb, pick the target determinant, pick the outcome or outcomes you want to work on, the population is precisely that denominator population that you're going to use, and then the time frame. So for instance, for Mrs. M, the story that we used, our intervention, 1 sentence was, we're going to prevent housing-related illness, housing-related being the determinant, illness being the outcome, among adult patients ages 18 to 64, which is the population, and the time frame between December 2011 and March 2012. That's an example of how to create that one sentence. Pause now and do that now, or come back to this later and write that down, and you'll have made a huge step forward. The next part of the next step in the action plan to move medicine upstream is to design the evaluation plan. Now, evaluation and planning go hand in hand, and this is often an area that we aren't either trained in as clinicians and don't get enough support on as we do plan interventions, either in the biomedical world or certainly in the biosocial space that we're entering now. So it's important to consider basic questions: who, what, why, how, or when. And the who is, who are the people that you're going to intervene with? What are the outcomes that best describe your project's impact? Where is that impact going to happen? Why are you conducting the evaluation, and to whom will you present it? This is important for both the planning stages in general, but specifically for the evaluation. When are you going to provide your intervention? And similarly, what's the time frame for your evaluation? Are you going to do the evaluation concurrent with your intervention, or are you going to do it at the end? Who is going to be involved in helping to evaluate this and also to implement this intervention? And what other data and tools and data collection methods are available to you? Is it just using the medical charts? Is there a small one-page survey tool that you'll develop? Is it a online SurveyMonkey tool that you can develop, and so on? Now, for the purposes of today, we're going to focus on just what outcome will best describe your project, because this is an area that is often the least precise in the development of interventions. So here's an example to drive home why outcomes are so important, and how also in general to create an evaluation plan. An intervention that a clinic came up with is to enroll food insecure diabetic patients for food stamps between December 2011 and May 2012. They defined who they were going to serve. They described their outcome, which we'll talk about in a second. They described where. They described why they're going to do this. The time frame: Mondays, Wednesdays, and Fridays for 6 months. They described the evaluation team and implementation team for them, and so on. Now, for the outcome, it's important to be really as precise as you can about this, and it's okay if you make a choice in an outcome that means that you're trading off one outcome compared to another, but it's important to be precise, better as opposed to being imprecise in choosing your outcomes. So the outcomes tell us many things, and there's different types of outcomes you can choose. You can choose outcomes that relate to patient health status or behaviors. You can look at outcomes like the utilization of healthcare services. Maybe you're looking for a decrease in the amount of acute care episodes that diabetic patients are experiencing because you've intervened to address transportation issues. You can look at outcomes in healthcare access, in improving benefits enrollment, for instance. You can look at provider level outcomes, provider satisfaction, and provider sense of preparedness, for instance. Or you can look at the social determinants of health outcomes themselves. Are you improving housing conditions? Have you improved transportation access, and so on? And that will be informed by the type of intervention you've chosen: a tier 1, tier 2, or tier 3 intervention. So write down the outcomes that you think are most applicable to your proposed intervention based on the last activity, and then as you've done that, when you've started to work on this or take an existing intervention and started to refine it, it's important to consider, and we're not going to spend too much time on this for right now, the importance of implementation and how to implement well. Thankfully, in terms of implementation, many of you are probably aware of different tools that allow you to provide implementation in really effective ways. There is the rapid improvement model that was developed by the Institute for Healthcare Improvement that looks at short PDSA cycles, like plan, do, study, act cycles, and looks at the repeated use of small, narrowly focused PDSAs to lead to a change that can lead to an overall improvement in your clinical world. This is a wonderful resource, and there's many others that many of you are familiar with. And chances are, if you're a clinician right now, you have a good sense of how to put together and implement a project. It's important to use resources that are out there, and there are many more. Now, in terms of collecting and reviewing data, there are also wonderful examples that are out there of how to do so. And this is one that's particularly important in terms of many clinical experiences, which is the enabling services. I mentioned before that enabling services represent about 7% of the services, patient visit types that are reported by community health centers across the nation. This is an example of how you can maybe use your clinic's enabling services and improve the way we're collecting data, so that you can make the case that enabling services are really integral to your business plan and to your care delivery system. So there are many different types of enabling services represented here. Oftentimes, though, clinic staff provide many of these services daily, but often don't track them well. And if we can't track them well, we can't argue for more funding for them, and you are less able as a clinician to use them to improve patients' health. Now, it's clear this is important because enabling services may be associated with better health outcomes. This is a report that was put together, again, drawn on information from HRSA, and also put together by the Enabling Services Accountability Project, run by an association of Asian Pacific Islander health centers. And in general, it's clear that we need to do a better job in data collection for enabling services, just like other social determinants of health interventions, because enabling services themselves are inadequately funded, and there are other major considerations in terms of impact that we have to be able to describe. Here's an example from Asian Health Services, a member of that consortium I alluded to earlier, and what they do is to document on an encounter log sheet their enabling services, and they have defined specific criteria to make sure that they're using standardized approaches to collecting data. They collect data on enabling services when it's linked to a medical service, when it's provided by a clinic staff member or volunteer, when it's provided to a registered patient as opposed to a random person walking in off the street, and when it's provided for 10 minutes or more. And this clinic then uses these log sheets, they collect them, and they enter that data into an electronic database. Here's a snapshot of the log sheet that they use. It's robust. If you want to pause here and adapt this, or to contact Asian Health Services directly, we can help you to do that. But this is a wonderful tool to better document and collect data about enabling services for each encounter type, for each patient. Now, here's the reason that collecting data and reviewing data is so important, and specifically why enabling services themselves represent such an opportunity to both improve health where it begins, but also to meet your clinic's priorities to become medical homes. If you look at the enabling services categories, and this again was compiled by the Enabling Services Accountability Project, but if you look at enabling service categories, you can link those to specific medical home standards, and those medical home standards mean that you're better able then to achieve higher tier medical home recognition, which itself will likely be linked to higher rates of funding and reimbursement as healthcare evolves over the next 5 to 10 years. So this is a really concrete example, and I think an unexplored kind of area, an opportunity for clinics that have enabling services to link them to the current priority that they have, which is to become a medical home. And if you do so, you'll be ahead of the curve. This is an example also why it's so important in your intervention to think about your enabling services as a wonderful way to a jumping point, a start-off point for your social determinants of health intervention. When you have put together the intervention, or if you're going to refine an existing intervention, it's important to not only design it well using the steps we outlined, to implement it well using the tools that we described, and to collect and review data, but it's also important then to celebrate that success each step of the way, to share those experiences on forums like the Primary Care for All website or in other venues, and to spread that knowledge and your experience and your story to other clinics. It's also important to use the words that matter. Through this entire presentation, I've been describing social determinants of health interventions. That's a lot of words to describe something quite simple. And it's not surprising that 84% of Americans, according to the Robert Wood Johnson Foundation, tend to view their health as something largely under their control and for which they have to take personal responsibility, as opposed to seeing it as something that's influenced by conditions upstream. However, after seeing effective messaging, the shift in the percentage of Americans who choose social factors, in other words, determinants of health, there's a noticeable shift in the percentage of Americans who describe social factors as having significant influence on health, 31% increase after seeing effective messaging. So let's talk really precisely, especially at every stage in your intervention, but especially if you're going to spread your success, in making sure that you're using words that work. These are not the words to use. The WHO provided an academic framework. I highly recommend that you do not use this when you talk to other people about social determinants of health. In fact, you may not want to even say social determinants of health. Traditional phrasing, according to the Robert Wood Johnson Foundation and other researchers regarding social determinants of health, shows that it consistently tests poorly among any patient population, and frankly among clinicians as well, I imagine. It's important to prime audiences about the connection between social factors and health using messages that they already believe, so that the concept is more credible. And it's important to not only identify the problem, but to offer potential solutions. Today, for instance, we walked through an action plan and talked about potential ways to make this work really concrete so that you can enjoy the work that you do more. Here are the words that work according to the Robert Wood Johnson Foundation. And I want you to think back to the answer to that question, that first activity, if you don't mind. When I said, what was that one word that comes to mind when you say health? Whatever that word is, you're right. You know, in my clinical setting, I asked my MAs, and together we developed a small experiment where we asked that question of patients. So we not only collected chief complaint information, but we also jotted down the one word that came up in patients' minds when we said health. And so when I walked into a patient's room, I saw that they were there for the chief complaint of a headache, for instance, but I also saw that the one word that they used to define health was well-being, or in some instances, oatmeal or bananas, just random things that come up. It's a wonderful way to engage with the patient, but for this activity, whatever your answer was, it's important to understand first that you're right. That's how you define health. It'd be intriguing to understand why you use that word. But no matter how you define it, the Robert Wood Johnson Foundation says that the messaging regarding health is effective when you use these three methodologies to describe determinants of health. So no matter how you define health, your opportunity for health starts long before you need medical care. No matter how you define health, health starts long before illness in our homes, in our schools, and in our jobs. And no matter how you define health, all Americans should have the opportunity to make choices that allow them to live a long, healthy life, regardless of their income, education, or ethnic background. Those three phrases were the three most highly scored and tested phrases, and if you want to use evidence and an evidence base to decide about how to describe social determinants of health, I highly recommend that you use those phrases when you talk with your colleagues, with family and friends, and certainly with your patients about health. And it's important, especially if you're considering the intervention at the beginning, in the design phase, in the implementation phase, and especially in the spread phase, to make sure that you're telling your story. Find the Mrs. M story that allows you to talk about why you are so passionate about this work, and make sure that you tell your story and your role as a clinician who is uniquely positioned to bear witness to people and the biosocial phenomena that shape their health. Tell your story so that it comes across loud and clear as you're spreading this. Today, hopefully, you've been able to understand a bit more about how to effectively communicate about determinants of health, what determinants of health really mean for the health of your patients and your communities, to describe the potential benefits to your clinic and to your professional satisfaction for using a population health approach, to describe at least the basic elements, especially in the design phase, of an action plan, and to identify some opportunities. And we talked about the PatientCentered Medical Home quite a bit, but also the enabling services and geomapping tools certainly exist. And these are all opportunities that can be leveraged to improve social determinants of health, and also to improve the way you provide care in your clinic. Mrs. M came to the clinic about 3 months after I saw her, and her health and her housing had improved. She did not go to any more emergency rooms. She had not undergone any more CAT scans or spinal taps. She had not lost significant days of work due as much as she was before due to her headaches or allergic rhinitis symptoms, because we treated her symptoms and we also improved her housing conditions with her on board as a partner in that. She asked one question, though, when I saw her, this was in June, a few months after I first met her, and her question was, why didn't the doctors ask me about my home before? I didn't really have a good answer for her. I think that our choice today is to either continue to poorly manage the consequences of bad policies using the current standard of care, or to choose a higher standard of care. And I trust that each one of us, because of our professional and personal responsibilities and ethics, would want to choose a higher standard of care. And I look forward to hearing more stories about how many of you are doing so as you spread your story and talk about the impact you've had in improving determinants of health, and specifically in moving medicine upstream. Health Begins is something that we've started, my colleagues and I, to really move medicine upstream, provide clinicians with the tools and the trainings In December, we're going to be beta releasing a social network that allows for just more streamlined engagement so that frontline clinicians and public health experts and the innovators who are working on determinants of health can really come together and just help you out. So if you're a clinician looking for help about dealing with housing, if you're a researcher who's looking for ways to talk to clinicians and understand how housing impacts health, or food security or transportation, etc., we want to provide the social network so that you're able to communicate more effectively. And we look forward to working in partnership with the community of organizations that are moving this cause forward, like the Association of Clinicians for the Underserved, like Primary Care for All, and the folks at Morehouse School of Medicine and the National Center for Primary Care, certainly my colleagues in the National Health Service Corps, and again, thanks to the Prevention Institute as well for their support in this process. Thank you so much for joining today. I hope this has been helpful, and look forward to hearing about all the work that you're doing as we go forward.